This week on the BackTable podcast.
I think it's fair to say that most of our listeners on BackTable, we're all sort of on a quest to continue to be independent. We're all on a quest to have autonomy with our practice. Yeah.
That's so cool. You're absolutely right.
Sometimes we have to reshape our thinking on things. We have to redefine our thinking. And I don't think that independence is any different. I just don't think that being independent and collaborating have to be mutually exclusive. I think they can exist with one another. Partnering with other entities is not a bad thing. I think it will certainly lead to contentment within our careers.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on Apple Podcasts, Spotify, and on BackTable.com. First, a brief word from our sponsors.
ClosureFast radio frequency ablation system. The technology you know and trust is now offered in a lower 6 French profile. Find out from Medtronic engineers what a lower profile means for flexibility, navigation, and kink resistance at medtronic.com/ClosureFast6F. Now, back to the episode.
My name is Thomas Sullivan, and I'm an interventional radiologist at Wake Forest, and I have the honor and the privilege of guest hosting on a topic that is quickly becoming very near and dear to me, unique rural practices. 20% of Americans live in a rural setting, but according to a recent questionnaire that we reported previously in a BackTable episode, 5% of our current IR trainees want to do IR in rural America. Today, we're going to talk to one and learn about his unique practice. Rural Americans have less access to care, including having to travel longer distances for routine services. They are less likely to be insured and more likely to die prematurely from common killers, including heart disease, cancer, and stroke. Incidents of drug and alcohol abuse, addiction, and suicide are also more common in Americans living in rural settings, with geographic isolation contributing to poverty, unemployment, and increased consumption of processed foods leading to obesity and diabetes. Sounds like an excellent opportunity for a CLI practice, doesn't it, Fred?
Oh, yeah.
My guest today is the wonderful and dynamic Frederick Johnson, MD, in Thomasville, Georgia. Tell us about yourself, sir.
Hey, Thomas, thanks a lot for having me on the podcast. This is a tremendous opportunity, and I'm very grateful for it. My name is Fred Johnson. I'm an interventional radiologist in Thomasville, Georgia. It's a small town of about 19,000 that's in southern Georgia. We often get asked when I tell people that I'm from Thomasville, say, "Oh, you're from Atlanta." But it is not Atlanta at all. In fact, we're about 4 hours away from Atlanta. But it's a small community of about 19,000. I have one hospital system here, and I'm a part of a sole IR practice, separate from diagnostic radiology. But we've also incorporated a surgeon into our practice as well.
And tell me about your background and a little bit about your training.
Yeah, so I'm originally an Arkansan, so from Arkansas. I was born and raised there. I actually got into radiology because my mom, she's an X-ray tech. So we grew up in a small town. It was actually smaller than Thomasville. Sort of a funny story. My mom, whenever she was on call, often had to stay in the hospital with her because my dad worked the night shift. So when she was on call, I'd go to the hospital and I literally slept there. I ate food there, ate my dinner, and showered there, and got up and walked from the radiology department to school as well. So radiology was definitely in me from the start. But we didn't have interventional radiology, so I really didn't know much about interventional radiology growing up, and only found out about especially once I got into med school. I did med school at the University of Arkansas. There's only one med school there, and ended up doing my residency in diagnostic radiology there also. And eventually got away from the natural state and did my fellowship at the University of Illinois, Peoria.
And then tell me how you ended up in Thomasville, Georgia, a town of 19,000 people.
Yeah. So after I finished my fellowship in Peoria, I joined a practice in Tennessee, in Jackson, Tennessee. And I was there for about 5.5 years. And it was actually an incredible opportunity for a burgeoning IR. The practice had just a very robust IR section, just doing everything in IR, from peripheral work to interventional oncology, doing EVARs, carotids, all the bread and butter. And so it was really the perfect practice to start, because it allowed me to hone my skills. It was a part of a traditional DR IR group, and so there was a DR component to it as well.
EVARs and carotids hardly sounds like bread and butter to me, sir. I think that sounds pretty cool.
Yeah, no, it was an excellent opportunity, and it was a really good run for the 5.5 years that I was there. Unfortunately, in 2017, I had some life circumstances that occurred and ended up becoming a single father to 2 little girls. And after that, my daughters and I, we just needed a fresh start, just needed to hit the reset button. And I knew that I wanted to be in an IR practice that still sort of paralleled what we had there in Jackson, meaning in terms of the case mix, the level of complexity of the IR cases. But I just needed a little less quantity of the work because frankly, I just needed to be a good dad to my daughters. And that's how I ended up in Thomasville. I ended up finding out about this IR practice they were solo IR. They weren't a part of a diagnostic radiology group, and they were essentially doing the same case mix that we were doing there in Jackson, but with a little less volume. And so I reached out to the guys, and it was probably about 2 days after they had posted their job on the SIR forum. And the first time that I called, we talked for about 2 hours, and I think things just aligned. They had something that I was in need of, and it seems that I was able to provide for some of their needs as well, and came out and visited Thomasville, Georgia, a place I'd never heard of before. I didn't know a single soul here, didn't have any family here, any friends, and things just aligned, and here we are now 4.5 years later.
So you're approaching 10 years out, so you're considered early to mid-career at this point. And it sounds like you're flourishing.
Yeah. No, it's been a really good first decade in my career. And the practice here, it's everything that I've been looking for. It's a very broad practice covering essentially all parts of IR with the exception of stroke. We don't do stroke, but as we did in Jackson, we're doing EVARs, we're doing carotids, we're doing peripheral work. A large part of our practice is dialysis work. So a lot of fistulograms, declots, and even percutaneous fistulas, and doing a lot of the bread and butter as well, nephrostomies and cholecystostomy tubes. And it's just a very diverse practice that has provided for significant professional satisfaction for me.
So from my standpoint as an academic interventionalist, the idea of a practice in this setting completely separate from DR is extremely unique, but it's intriguing and it's very interesting. Can you tell me about the history of the practice and kind of how that came about and what happened to result in this current scenario that you're in?
Yeah. So diagnostic radiology and interventional radiology actually separated here in Thomasville in 2006. So more than almost 20 years ago. When I talked to the diagnostic radiologists who were here at that time, they tell me that the split essentially came about because of the call responsibilities. At that time, they had one interventional radiologist, and she was covering both interventional radiology as well as diagnostic radiology. And so the call just became unbearable. And at that time, she was doing pretty high-end work, a lot of thrombolysis, a lot of drips, patients in the ICU, and of course, all the other things, the GI bleeds. And so she was having to tend to the IR practice, but also having the expectation that she would cover some diagnostic radiology work as well. And it just became a bit much for her. And so the decision was made that DR had to split from IR. And at that time, they actually brought in 2 guys who was sort of a locums, but they were sort of tasked with keeping the IR section stable so that they could get just the IR group itself off the ground. They were here for about a year, and then they ended up bringing in another interventional radiologist who actually started my current practice, Fast from Interventional Thomasville Associates. And after he came and started the practice, he actually found himself alone about 3 months after getting here. And he was actually alone for about a year. So he's pulling call every day by himself, and eventually ended up recruiting a partner who's now still with me as well. And the practice just continued to grow over those first 10 years, and they were an independent practice. All of their reimbursement came from purely with the work that they were doing. But around 2017, they ended up having to make some changes in the business model, and we can discuss that here in a little bit.
So yeah, let's get into that. I think that's really what's very interesting here is the idea that you're able to service a hospital of 200 beds or so and still manage to sustain yourself without a DR group.
So from 2007 to about 2017, that was during the day where the reimbursement for professional fees, they were much higher than they are today. And so the guys, they were actually able to make it work. They were able to have a clinical practice that they had their own clinic. And that in and of itself is a story. And they tell me it initially started with a room, just a small room in the hospital that they were renting. And it was a fairly primitive practice. But they eventually ended up moving out of the hospital into another office where they were renting space. Sort of a funny story they always tell me is when they first opened this clinic, it was during the early days of the clinic for IR, and they'd have patients come in and they'd reach in their wallet or reach in their purse and they'd bring a card out. And the first few patients that came through the door, they asked me, like, what is that? What is that you're giving us? I said, well, this is our insurance card. And he said, oh, no, you can put that away. We don't need that. It just shows that it was definitely the early days of the clinic of interventional radiology. The clinic continued to grow, and they eventually got their own clinic space as well. And so they had more space, ended up getting more staff. And of course, all of that, it cost. And this was during the time where the reimbursement for professional fees were going down, and the partners found themselves being out of more and more income. And they had to figure out a way that they could continue to be independent, have their own autonomy, but also just continue to provide the level of service that they had been doing. And so that's how they actually ended up partnering with the hospital here by way of what's called a professional service agreement.
So take me through that. I think I think bringing up some of our trainees and some of our early career listeners, a diagnostic radiologist is able to generate revenue much more efficiently and quickly than an interventional radiologist when it comes to professional RVUs. Whereas in IR, we are paid based on what we do. And that model is not necessarily sustainable in the context of decreasing reimbursement. So we have to acknowledge, okay, well, IR does provide value to the hospital. You need the service. And if you paid us based on our doing paracentesis, thoracentesis, and drains, nobody would want to do it. So what Dr. Johnson has done is they have what's called a service agreement. And that kind of mitigates the fact that they would not be able to pay their employees and pay anybody's salary based on hospital work. So take me through some of the structure of a service agreement.
So with the professional service agreement, it's a mechanism for two entities. And for the sake of this discussion, those two entities is the physician practice as well as the hospital to fulfill their needs. And how the PSA really works and what makes it work is that it encourages collaboration between the two entities. And so with the physician practice, they had a need for financial stability. That was the reason that they approached the hospital, is that they needed financial stability to help sort of ease the pressure of the overhead of the clinic. The hospital, they have their needs as well. They had established a service line of interventional radiology. They have call coverages that they need for IR. And so the PSA, what it does, it allows for collaboration for the hospital to fulfill their needs for, be it the service line, for the call, but also for the needs of the practice to be met for the financial stability as well. And PSAs, they can be arranged very differently. And the PSA was something that I actually was not familiar with when I moved here. And in fact, when I was interviewing with the guys, there was some significant concerns for me about a PSA because it looked very different from my previous practice. I didn't know if it was really independent per se. And the guys, they really had to explain to me what this PSA meant. They really had to sort of convince me that they are independent and that the goal of the practice was to continue to remain independent and autonomous. And so How our PSA works is that we actually work with the hospital. We partner with the hospital. We collaborate with them where we can come up with a budget each year. And what this budget does, it helps us to support our clinic, because the clinic is the most important part of our practice, in my opinion. That's where the high-end procedures, the angiograms, the EVARs, the carotids, the Y90s, they don't happen if there is no clinic. If we just sit in the hospital, we're not going to get these high-end cases. And so the clinic is vitally important. And the PSA just provides a way for us to continue to support the clinic by way of salaries for our employees, their benefits, actually the rent for our practice or the building itself, which we own. And then in turn, what the hospital gets is an interventional radiologist service line. They get 24/7, 365 call from interventional radiology. And so in this way, both sides are benefiting, and it's mutually beneficial. One side's not benefiting more so than the other. And it's not an employment model. It's a way for the two entities to collaborate and partner with one another. And it's a way for our practice to continue to remain independent and autonomous.
So when you and I met last fall at SEAS, I was talking about some of the disenfranchisement and disappointment that a lot of our trainees are experiencing when they come out. And one of those issues is lack of autonomy and lack of professional satisfaction. And to me, it sounds like in this setting, you're able to find both. Your PSA enables you to serve your client, which is the hospital. You have autonomy as a business owner, and you're working toward E&M generation. You're working toward patient satisfaction goals. You're working toward financial initiatives that aren't serving a private equity group. They're serving yourself.
That's correct. No, absolutely. To sort of expound on that, with the PSA, as I mentioned, it helps to ease the burden for the clinic, undoubtedly.
So clinic's expensive. You have to have. So tell me more about some of those expenses.
Yeah. We have about 16 employees, 16 to 18 employees. And so with those employees, their salaries are the main part. That's the most expensive part of our clinic. It's the salaries. So we have to have a way to ensure that these people are paid fairly. Then along with the salaries come all the benefits, health insurance, vision insurance, dental insurance. Then there are things like CME. A lot of our employees, like our ultrasound techs, our advanced practice providers, they utilize CME for that. And then there's retirements, there are 401ks. So we're just like any other business. We have to provide all of these benefits for our employees. And it can be a considerable cost with that.
But with that, you have autonomy, right? You have HR, and you can recruit people that you like and that you enjoy working with.
Exactly. Yeah, absolutely. And that's the beauty of it, is that our employees are our employees. They are not employees of the hospital, and they function under VITA. And I think that's something that they really appreciate. They actually tell us that often, because our practice is ours. We've actually structured it in the way that we want, in every way. Again, from who works for us, the benefits that we have, and even once we get down to the physician level, how much time off. We determine that. How does our clinic work in terms of who's working in the clinic on what days?
Tell me about how you split the practice and you split the service. And so someone who might be considering this model, anytime I've gone on a job interview, I've asked the person that's sitting on the other side of the table, okay, take me through the structure of your practice, take me through your day-to-day, and how do you guys run the shop?
So there are 2 interventional radiologists currently. There's typically 3 of us, so we are currently recruiting. And so I'll just sort of speak for how things are presently. With the 2 IRs, we cover the hospital. And so you'll have one guy who's on call and one guy who's backup. And how call is just that you're at the hospital all day. You're covering all the procedures that are coming in.
You're doing all the cases. That's you. Okay.
Exactly. The back-end guys, they're to help decompress and support the on-call guys. So all of the cases that are coming in, the scheduled cases, the emergencies that come through, you help to decompress that. But the backup guy also uses that week to do a lot of their elective cases. And in fact, I tend to load up most of my elective cases during my backup week because I know that I don't have to worry about the GI bleed that may come through, the PE thrombectomy that may come through as well.
So you mean that you don't make your elective patients wait for hospital cases?
Oh, no.
So customer service? That's fantastic.
There you go. Absolutely. And that's what it's about, right? And the thing is, when we get into these scenarios where patients are having to wait, for hours, and dialysis patients that come in for declots and they're getting done at 6, 7 o'clock at night, that's bad customer service, and that leads to losing business. And so the way we have it structured, it's very intentional, and it's geared toward satisfaction of our customers, which are our patients. To get back to a little bit of the structure of the day in the clinic, typically with the backup guy, they'll be in the hospital in the mornings from about 8 to 12:30 or so. Then they go to the clinic and they work the clinic that afternoon, usually from about 1 to 4:30. So they're just seeing patients each day. Typically it's Monday through Wednesday. And that way we can continue to serve our customers and our referring providers, get the patients seen in a timely fashion. Obviously, we have to have vacation. And so on vacation weeks, that means there's usually just one IR who's there at the hospital. And the clinic, what we will typically do is ask our advanced practice providers to assist us at that point.
How many providers do you have that are APPs or PAs, MPs? What does that look like?
Yeah, so we currently have 3 advanced practice providers. They are nurse practitioners. On the surgery side, they actually have PAs as well. So how the advanced practice providers, how they function is 2 of them will typically be at the hospital. And so they help us out with just getting through the workflow. They'll see all of the consults that are happening on the floor. They'll follow up on the patients that had procedures the previous day as well. And we see these patients with them. And so typically they'll go and see the patient first, and they'll get the rundown of what's going on, and they'll come back and present to us, and we'll typically go up on the floor with them and see the patients and just to kind of round out the consult and make sure that we can answer any questions that the patients may have as well. And so then we also have one APP who functions in the clinic. Now, it's always been our philosophy that 95% of all new patients that they are seen by the physician first. So it doesn't matter if it's something like venous disease, if it's PAD, we generally like for our patients to see the physician first. And once we see the patient, we develop the care plan. And after patients have their procedures, most of the follow-up is then provided by the APPs. And they are just tremendously helpful for us. They're very good. They love IR. And so it's just been a model that we've kind of crafted, and it works for us.
So it sounds to me like you guys are about 10 years ahead of anything that SIR has laid out for an ideal practice. I mean, this sounds exactly like what we're trying to get our trainees to walk into and do.
Yeah, well, I've got to give credit where our credit is due. This was a well-oiled machine before I got here. It was a very mature practice, and I really just sort of stepped into a ready-made practice. I'm very thankful for that. Now, has the practice grown and evolved since I've been here? I like to think so, but I have to give credit to my partners that they really got this train rolling before I got here. It was a very, very mature practice.
So getting into a little bit more of that, can you characterize your relationship with some of the other services in the hospital and what it's like to practice in this kind of setting?
Yeah. So one thing with practicing in a rural community is that it's obviously small. There are a limited number of physicians. And so in that sense,
got to mind your P's and Q's.
You got to mind your P's and Q's. That's right. Exactly right. And you have to play together. You just do. You have to work together. And that's one of the reasons that I wanted to work in a rural community, is because it does force us to all play together. It forces us to be collegial with one another. We all have each other's cell phone. We'll call each other at 5:30, 6 o'clock at night when patients need care. And so very thankful for the relationship that we have with our different specialties. We have essentially all specialties with the exception endocrinology and infectious disease. And so we work a lot with urology, work a lot with general surgery. Again, I have a general surgeon in my group, work a lot with the thoracic surgeons as well. It's a very, I think, a very respectful relationship that we have. I believe that they respect us. I believe they actually see us as true clinicians. They don't see us as proceduralists. You can just put an order in and things will be done. In fact, for most of our high-end procedures, those patients are sent to our clinic first. You don't put it in order and it's printed off in the IR lab and it's done.
Does it print off from a fax and then some elf materializes from the wall and puts in a perm cath?
Right, exactly. Yeah, exactly right.
Tell me about the surgeon. Why do you have a surgeon in your group?
Yeah, so it's the surgeon. He actually joined our group at the time that I joined in January of 2020. He has a long tenure here. He's been here probably more than 20 years. And he ended up joining the group. They had some dynamic changes in the group, and he wanted to continue to practice in vascular. He's not a fellowship trained vascular surgeon, but he came up during the time during his residency. He had a lot of emphasis in vascular, so did extra rotations in vascular surgery, and so he still does things like fem pops, fems. A lot of the open vascular work. He does no endovascular work.
It's fantastic.
Yeah. And much of his
what a great
practice,
resource.
it really is. And we complement each other well. He's able to do a lot of the open work. We obviously do the endovascular work. Much of what he does is dialysis work. He probably does about 95% of the dialysis work here in the community as something that he really enjoys. And he's also over the wound care center as well. So that tends to be his passion, wound care, as well as dialysis work. And so it's worked out tremendously well for us. And we just complement each other. Again, it's that theme of collaborating and partnering in ways that we can help each other.
And then what about your relationship with diagnostic radiology?
Yeah. So again, the two groups, they separated back in 2006. But ever since I've been here, it's always been a very amicable relationship. We respect one another. In fact, from a hospital standpoint, they have a radiology council. And so that includes both DR and IR. We actually rotate the chairman of the council every 2 years. So for 2 years, it'll be IR. The next 2 years, it'll be diagnostic radiology. And I really, really just appreciate the relationship that we have with them. There's certainly no contention between the group.
That's fantastic. Tell me about your relationship with the hospital.
Yeah. And so that's something I'm very grateful for, but admittedly, I didn't know what to make of it when I first came, just because, again, it looked very different from It's
an unknown. It's weird. It's different.
It is. It's very different. And the relationship, it just didn't really fit the framework that I was used to. But as the practice developed over the years, they really began to sort of align with the hospital, because again, they both had needs. And that's how the PSA ended up coming about, just because both sides appreciated the relationship between the two.
Well, you get one or two good hospital leaders, a good CMO, and a good COO, CEO that truly understand the value that our services bring to a hospital, and the world is your oyster.
Exactly right. And so with the hospital, we talk with them very often. Again, we set a budget each year so that our practice can continue.
So that's materials, or is that what do you mean by, is that time? Is that lab equipment? What do you mean by budget?
Primarily for the clinic.
Okay.
It's primarily for the clinic, so we can continue to keep that going so that it's healthy, because again, that's the most important part of the practice. And we negotiate every year. It's not contentious. Ever since I've been here, there really hasn't been any pushback in terms of things that we've asked for. And we're very reasonable. We don't go overboard things, and we sit down with one another usually around mid-year, and decide how the next year is going to look. And we present that budget to the hospital. And again, there's rarely any pushback with it. It's just a very amicable relationship, and they just allow us to run our practice. And as we understand it, they are totally content with being hands off, and that's just one less practice that they have to worry about to handle the HR issues and everything else that's involved with managing a practice.
It's like, listen, guys, we got this locked up. Just we'll take care of IR. That's one thing that you guys don't have to worry about. And being able to use that kind of language with the hospital CEO is invaluable.
Yeah, no, absolutely. Absolutely.
So we've been ranting and raving about some of the fantastic things about this setting. And for the last several years, I can't imagine that it's been all sunshine and rainbows. Can you tell me about some of the pain points and some of the challenges that you're encountering in this setting?
Sure. Yeah. So as much as I could go on about the mix of cases and how great the practice is, we certainly have challenges just like every other practice does. Probably our biggest challenge right now it's recruiting. We need a third IR, but it's been certainly a challenge to recruit to a small town. We're no different than most others, and there are different reasons for it. We'll have people that'll come and interview with us. They see the practice, they rave about how great it is. But the truth of the matter is that it's not just about one person, especially if someone has a partner, a significant other, they have to sign on as well. And what we've seen is that when the IRs come here, they appreciate what they see, and they're on board with that. But then when it comes to the spouse or sometimes even the children, we have to convince them as well. And there are different reasons that small town may not be for them. A lot of times it's just access to different opportunities, access to different resources, and we get it. It's certainly not for everyone. Some of the other challenges that we face is that the practice, it's a good challenge, it's a good problem. The practice is growing. The cases are increasing, and we're needing more space. We're needing more staff, and we're really busting at the seams right now, just with space. And we've had to resort to renting space that's not on our main campus as well. And so just kind of the limitation on our clinic and the space itself that's creating some challenges, but I guess it's not a bad problem that practices continue to grow.
So getting back into recruiting, there are creative ways that I've seen rural practices entice young people coming out. One thing that I was certainly looking for was kind of a stratified practice model where you had people that are more senior and then more mid-career and then more junior. And it kind of sounds like you have that. And then another thing is obviously compensation. So can you speak to that at all? Like in terms of whether you feel like you guys are competitive? Because from what I've seen, a lot of rural jobs, there's that job that everybody knows about in, North Dakota that pays really well. That's always available. And a couple of those, but also at the same time, you're marketing what ultimately ends up being financial freedom for people that are coming out with $250,000 to $500,000 of debt. And so that there has to be some kind of appeal there. Are you guys addressing that at all?
Yeah. And that goes back to the relationship with the hospital that you mentioned. They've been very supportive of us in the recruiting effort. And one thing that we've done here, and I took advantage of it, is that for the IR that's coming in, we provide an income guarantee for the first year.
Okay.
And so there's less of a burden on that individual to have to just quickly ramp up and get their practice up and going. And so they have an income guarantee that will support them with that. And we're very grateful for the hospital for providing that. In terms of income, what's built into the PSA is it's an RVU factor as well. So we are actually paid per RVU. It's an appreciated RVU with a little bit of an increased valuation relative to just a usual professional fee. And so it helps to, one, continue to have a broad mix of cases. If we didn't have the RVU factor, we'd have to somehow worry about stacking our days full of 50 or 60 cases. And so it helps to, one, continue to have a broad mix of cases. If we didn't have the RVU factor, we'd have to somehow worry about stacking our days full of 50 or 60 cases. And so it helps to, one, continue to have a broad mix of cases. If we didn't have the RVU factor, we'd have to somehow worry about stacking our days full of 50 4 and 5 angiograms.
Right.
And
you'd have to do PE thrombectomy for 7 days a week for 7 to 8 hours in order to recruit anybody.
Yeah, exactly. But what the PSA does is that it, in my opinion, it fairly values some of those more routine, low complexity procedures like chest tube, flourish catheters, ports, biopsies. And so it allows us to have a sort of a broad procedural practice where we're compensated fairly for it.
Very cool.
So we're certainly doing things to ensure that the income piece is taken care of, and we're also trying to ensure that the practice continues to have this broad case mix, because that does play into professional satisfaction. And being frank with you, that's really what keeps me here. It's the broad case mix, which has led to me being the most professionally satisfied that I've ever been.
Well, we're also talking about transitioning outside of an employment model. So I assume that you're an owner and you're not an employee. And so you're not a W-2 employee, and there are enormous tax advantages and financial incentives to not being an employee. Like, you have profit sharing, you can do cash balance plans, you can do solo 401ks, and there are fantastic financial products right now that are available to people that are somewhat self-employed that aren't available to employees. And I think that that's another power that might help with recruiting, is you get people to see, oh, wait a minute, you mean I get to keep this? This is mine. I get a K1. There are things here that could definitely appeal to somebody who actually has a little bit of a business accounting background that's a little bit savvy.
That's right. Yeah, exactly. And that's the beauty of the PSA, is that it allows us to construct our practice the way we want in terms of whether or not we're W-2 or 1099, whether or not we're S Corp, C Corp. We have that latitude with it. And so with us, because of the way our PSA is set up, we actually are W-2. Reason being is because the PSA really covers a lot of the expenses that we would normally write off. And so we actually are W-2 because those expenses are covered through the PSA. So we haven't really saw where it would benefit us much to be 1099.
Interesting. So you've looked at it and then you made that decision to be a W-2. That's very interesting.
Yeah, exactly. And we revisited a number of times just to determine if this would benefit us, but simply because a lot of the overhead is covered by the PSA. Okay. We just haven't seen there's a lot of benefit. But again, PSAs are very flexible. There are probably ways that they can be constructed where a 1099 would be more beneficial.
Very cool. So we've talked a lot about this PSA and kind of bringing things back around and bringing things a little bit full circle. You told me that IRs feel like they have to settle. They have to settle for a lot of different things coming out, whether it be geography, whether it be a practice setting that's ideal for them, whether it be an academic medicine or an OBL, or if it's something that, they really value. But also a lot of us that are early career value that professional satisfaction in doing the things that we were actually trained to do in our academic setting. So you told me that professional satisfaction, money, and the opportunity to really make this practice my own is really what fills your cup and what fuels you. Can you elaborate on that statement?
Yeah. What I've seen often with a lot of early career IRs, those that are coming right out of training, as the results of your survey showed, is that most have geography and locations number one on the list in determining where they go. And a lot of early graduates, they're going to metropolitan areas, and they're joining groups where there are lots of other specialists that do a lot of the things that we do. They just don't have the opportunity there to do the things that we're trained to do. A lot of the peripheral vascular work, a lot of the dialysis work. And so when I say that, when I see a lot of the early career IR settling, that's what I mean. I mean that they settle for the case mix. They settle for, honestly, their professional satisfaction. And I get it. I mean, we all have priorities. And for them, priority, it may be location. And it may be for different reasons. Maybe they need to be close to family, things like that. I totally get that. But I just think that there's a wealth of opportunity out there for IRs. There's just a tremendous need for IR. There are a lot of voids, particularly in these rural communities that could be filled by IRs, where you can do these things that truly bring professional satisfaction, where you can practice at the top of your license, so to speak, getting to do dialysis work, getting to do interventional oncology work, getting to do women's health. It's there. But I think it's going to take having to maybe think about things a little differently and approaching things a little differently in order to achieve that professional satisfaction.
So this just kind of begs the question, like, do you think that this kind of practice has to exist in a rural setting? Like, if you set up a shop and you take care of patients, you take care of the hospital, do you think that this model is translatable to a mid-sized city?
I think it is. I think there are probably more opportunities in a smaller community.
Okay. Why?
For it, but because of the need. I think when we get to these mid-sized cities, particularly larger cities, there's more competition. There are other players that are probably providing a lot of the things that we're looking to do, be it PE thrombectomies. There's a city that's probably 30 miles south of us, and their PE thrombectomies are done by someone that's not an IR. And so that's very different from the practice here in Thomasville. And so I think that would probably be the challenge when we start going to larger cities, that there are just simply more players that are able to fulfill a lot of those needs. I think that the needs are just there in a rural community, just ripe for someone to sort of take those on.
And then the professional satisfaction that you gain from seeing a patient in clinic, doing their case, and then following them up. That's what I want everyone that comes out of our residency to experience, and that's what I want everyone that's coming out of training to experience, is that opportunity to have someone appreciate you for what you do and see them in a longitudinal setting. And I would also definitely see the benefits in small town lifestyle. When I was living and working in Chicago, I would occasionally have an hour and a half commute to one of our more peripheral hospitals. And tell me about your commute.
It is not an hour. I can tell you that for sure. In fact, according to Thomasville standards, I actually have a lone commute. So it takes me 12 minutes to get from my house to the hospital. One of the many benefits of living in small towns is that pretty much everything is going to be within 10 minutes, be it getting to the hospital, getting to Walmart, everything's a short commute with that. And the other benefit of it is we don't pay for parking around here. it is free parking, and there is something to be said about that.
And like you mentioned, the collegiality and kind of knowing your referrers and knowing everybody really well, and kind of having a little bit of having your little bubble and your little environment that you exist in, and your ecosystem that you control and contribute to is a valuable member of the community. I think that's fantastic.
It's incredible. I mean, it makes this very meaningful. It makes it very purposeful, and you don't feel like you're just kind of going through the motions. You feel like you're bringing value to the community in general. Feel like you're bringing value to the medical community. Again, there's a respect amongst you and your colleagues, and the experience. It's been just something that I'm so grateful for. I never really saw it coming, and again, just the clinical practice, as you mentioned, just being able to see patients longitudinal, seeing these patients beforehand when they come in nervous, they're anxious, and you get to talk them through the procedure and alleviate a lot of that anxiety. You see them on procedure day, and things go well, and they're grateful. And then a lot of these patients, you see them for years afterwards as well. And so they just become a part of our VITA family. And to a certain degree, as they tell me, you become a part of their family. And it's here in South Georgia, again, it's rural. And so a lot of our patients, they're farmers, and they come in for their follow-up visits, and they bring us field corn, and they bring us peanuts, and it's an incredible experience here.
Well, kind of wrapping up, do you have any advice to offer anyone that might be listening to this and considering this kind of practice?
I sort of alluded to this earlier in that when I first came to this practice, and it looked very different from my previous practice in that the independent part, it was very different. They had the PSA, and I really had to come to terms with that. I think it's fair to say that most of our listeners on here, on BackTable, we're all sort of on a quest to continue to be independent. We're all on a quest to have autonomy with our practice. Yeah.
That's so cool. You're absolutely right.
What I've had to figure out is that sometimes we have to reshape our thinking on things. We have to redefine our thinking. And I don't think that independence is any different. Certainly had to reshape how I view being independent. I've had to redefine that as well. And that doesn't, that's not code for saying that, employment is independent, but I'm just saying that I've had to think of things differently. I just don't think that being independent and collaborating have to be mutually exclusive. I think they can exist with one another. I think that you can have an independent practice and partner with someone and still be independent. Independent doesn't just solely mean that, all of my remuneration comes from insurance companies and I get to make all of my decisions myself. The landscape of healthcare economics is changing. And I think it's going to behoove us to accept that we're going to have to collaborate. We're going to have to partner with different entities as well. But that doesn't mean that we're giving up our independence. And what we've seen here in Thomasville is that collaboration is really vital to the success of our practice. And I think for a lot of us, not only IRs, but different specialties as well, once we start to kind of reshape and redefine how we think about independence and realizing that collaboration is not a bad thing, partnering with other entities is not a bad thing, I think it will certainly lead to contentment within our careers.
Well, there you have it, ladies and gentlemen. Dr. Frederick Johnson of Thomasville, Georgia, with a fantastic opportunity and a very progressive model for the practice of interventional radiology. His contact information will be posted with the show notes as well as mine, and we encourage you to reach out. And as always, thank you very much for listening. Thanks, Frederick.
Thanks a lot. I appreciate it.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck, Sabine Dong,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.